Hi, good evening, everyone. This is Dr. Satya Yadav. On behalf of Society for Pediatric Cell Therapy and Transplant, I invite you today's webinar. And this is the one of the very interesting topic we are going to discuss today. That's metabolic disorders, bone marrow transplant for them. As we know, these are very rare disorders, and in India, with a country of 1.4 billion people, even rare disease are big number. They are not small. And at this point of time, as Dr. Sunita Bijania, who is here as a metabolic expert, we know that most patients never reach a transplant center or don't get a definitive therapy which they are eligible for or which they should. So awareness is lacking. So I think it's important that we discuss this topic today and all the transplant physicians, especially young trainees, log in and learn from it. So I welcome you all to this webinar, and I would like to invite the chairperson for today's session, Dr. Sunita Bijania, uh, who is the head of metabolic disorders department at Department of Genetics at Sir Gangaram Hospital, New Delhi. So over to Dr. Sunita to take forward and introduce the speaker. Thank you.
Thank you so much, Satya. It's such a pleasure to come here once again. And it's an equal pleasure for me to introduce the speaker, Professor Rob Wynn. So, Professor Rob Wynn is a consultant at the, just a minute, just like to open the slide. Yep. So Professor Wynn is a consultant at pediatric hematologist at the Royal Manchester Children's Hospital, and he's also the director of the Blood and Bone Marrow Transplant Program. He's honorary professor of pediatric hematology and cell therapy at the MAHSC. Professor Rob was born in Sudan and grew up in Liverpool, and he was educated at St. Edward's College, Liverpool, and did his undergrad medicine training in Cambridge University and now the London Hospital, qualifying in 1989. He trained in medicine in London, Newcastle, and Edinburgh, and in hematology in Cardiff, Manchester, and Toronto. Manchester BMT has two areas of specific expertise and interest. It has transplanted many children with inherited metabolic disorders, and Professor Wynn is a pioneer in this change. He has an interest and expertise in cord blood and stem cell source in transplant, including refractory leukemias. So his career has greatly been influenced by Professor Alan Burnett in Cardiff and Professor Ed Wraith in Manchester. Professor Rob has published innumerable papers, more than 230 peer-reviewed papers in hematology and bone marrow transplants, and he has authored textbook of pediatric hematology with Paul Monagle from Melbourne and Rukmi Bhatt from Chicago. He's also a lifelong fan of Liverpool Football Club and has a season ticket. So I must also introduce him as like the Messi of bone marrow transplant. So Professor Wynn, is over to you for your talk. Thank you.
Oh, thanks, Anita. Very kind of you. Thank you. I'm not sure about the messy bit.
Oh, you're not a fan?
Oh,
Okay. I should have said Salah.
yeah, well done.
Okay.
Great. So thank you ever so much. It's really nice to be here. I'm very happy to talk to you all and talk about metabolic disease transplants. And I think your introductions were very timely. So maybe these diseases aren't quite as rare as one might think. And with changing cell therapy and with us being able to treat refractory disease, then I think we may see many more of them in our transplant programs, and we can chat about that. So first, I'm going to talk about lysosomal storage disease, and I guess such things will always be the paradigm of therapy in transplants, are the commonest diseases we get to, and introduce this cost correction where engrafted donor cells deliver enzyme and they correct enzyme deficient host cells in all their tissues. And that's this concept cross correction. And I'll give some of the principles of how we transplant in Manchester. So the conditioning is myeloablative and busulfan based, and we use a lot of cord blood donors. And then I'm going to distinguish transplant, how we do the transplant from what about the disease and how we correct disease. And we'll discuss perhaps transplant sensitive, transplant refractory disease. So which lysosomal storage diseases get better with transplant and which don't. And therefore, what are our current indications for transplant in lysosomal storage disease? Who are we transplanting in Manchester? And these very important twin things that influence transplant, the disease outcome after transplant. So the disease itself, then the age at transplant and how much enzyme is delivered by the transplant. And we can talk briefly about other non-lysosomal storage diseases, which mainly in metabolic means XALD. So this is transplant. So here's the blood, and these are the donor cells, and the donor cells are giving enzyme which is secreted and delivered to the tissues. So that's how it might work in many diseases, maybe Hurler syndrome and the like. I think in some diseases they are predominantly macrophage disorders, and so just by engrafting the macrophage, you correct the disease. And I think Gaucher is probably a good example of that, and maybe Wallman disease. But in many of them, it's this principle where engrafted donor leukocytes make the enzyme and out it goes into the tissues. But because the leukocytes can cross the blood-brain barrier, then the enzyme can be delivered into the brain. And so if we look at drug treatments, like then the enzyme can't cross the blood-brain barrier, and so you can't correct neurologic disease, but the cells do. And again, as they cross the blood-brain barrier, they're engrafted as donor macrophages, known as microglia in the brain, delivering enzyme there. So when we think about transplant against enzyme, so you will see some of your colleagues delivering enzyme replacement therapy. And I think we talk a lot about illnesses like Gaucher when it comes to this, but also some of the other illnesses, MPS 1, MPS 2. So where enzyme is given. First of all, I think one of the big problems with enzyme, it's phenomenally expensive and requires lifelong therapy. So if you think about the Gaucher kids, although enzyme is effective in mild disease and type 1 disease, it's given every 2 weeks and it's not cheap, especially over a lifetime. It's the cumulative financial toxicity of enzyme replacement. But then when we look at transplant versus enzyme, it delivers more enzyme. It's a single treatment, delivers durable, lifelong enzyme. In the more severe diseases, you'll develop antibodies against the enzyme. So maybe not in type 1 Gaucher because there is a lot of residual protein. It's just not very functional. But in severe metabolic disease where there's a null mutation and no protein, the protein is immunogenic. And if you use enzyme, you just make an antibody. And if we look at our Hurler kids, when they come to transplant, they've often had some enzyme replacement before transplant, but they've all got high levels of antibody at the time of transplant. Now, the graft will be tolerized and that antibody will go away, but if that antibody will stop the enzyme being effective. And then finally, transplant allows delivery into the brain. So I think these are the reasons we would prefer you always transplant. It's cheaper because it's a one-off treatment. There's no antibodies against the enzyme that it makes. It gets into the brain and actually gives more enzyme. So when we look at Hurler syndrome, that's our paradigm disease. So the commonest single indication for transplant in metabolic diseases, at least in the UK, is Hurler. Probably the commonest lysosomal storage disease is Gaucher. And I get a lot of conversations from colleagues in India and elsewhere about Gaucher, many more conversations about Gaucher than Hurler. But Hurler is our paradigm disease. And we'll just review what our results are. We've got 3 kids on the ward with Hurler today, so it's not so rare in Manchester. So how good are our outcomes? What's made the difference? What about the different organs? How well do the children do? What is their quality of life, and how might we improve results? So here's a little girl with Hurler syndrome. Oops, sorry, just get rid of that. My God, what have I done? Sorry, let me just. Okay. So this is a girl with HERLA that's not had a transplant, and you can see that she's developmentally delayed. She will die of cardiovascular disease, usually by the age of 10. She's got learning difficulties. So you can see that she's got a multi-system disease. So small head, learning difficulties, a small head without hydrocephalus. She's got soft tissue abnormalities. You can see her hands. She's got a skeletal dysplasia as well. So she's got a spinal disease, hip dysplasia, knee dysplasia. She's got corneal clouding in there, and she's got cardiorespiratory disease, and the kids will die of cardiac failure. Good girl. Stick it up. Good girl. So when we look at transplant for HERLA, then this was from the 1990s. So what we can see in red is the natural history of the untransplanted disease. So it's a fatal disease. Most children dead by the age of 10, median survival between 5 and 10. So secondly, with transplant, capable of long-term survival, and some of the kids that we transplanted are in their 30s and 40s now, and still, it's the cardiovascular disease that generates death. And I suppose in the old days, this is an old thing, that there would be transplant-related mortality. So immediately after the transplant, kids are more likely to be dead from the transplant than from the disease. And of course, this is one of the difficult things about all of the work that we do in all of our patients. This is a patient that's had a transplant. So you can see in red is the enzyme before the transplant is 0, undetectable, and then after the transplant, this is leukocyte enzyme. You can measure the enzyme, it might bounce around a bit. And then the substrate, so the enzyme is iduronidase, and the substrate for the enzyme is heparan sulfate, dermatan sulfate. And you'll see that as the white cells engraft, they metabolize accumulated substrate. So this is urinary substrate, and so the enzyme is delivered from the leukocytes to the kidney, and from the kidney it metabolizes the accumulated substrate. So you can see this principle of cox correction. This enzyme in red is in the blood and in the blood cells, and then this substrate reduction is in the tissues. And it's a pretty effective treatment. So if we look at this little kid
With the same amount of energy.
So the mum's voice, she's Irish, and these are two identical twins that we transplanted from a single donor. So we took a single cord blood donor, we split the cord at the bedside and transplanted the two kids.
The energy of it doesn't change. Like I was expecting, I didn't know they're going to walk. I mean, I didn't know what to expect. And then they walked. And when they walked, and I thought energy-wise, and I thought because hurlers affects the bones, I thought that they'd walk, but
So you can see that these kids are talking, walking, playing, they're in mainstream school, their learning is good. And
much energy. It's just unbelievable. It does someone else.
So I think that that's a good demonstration of how good HERLA syndrome can be after transplant. These are our survival and engrafted survival. So this I'm showing you here on the right panel as we look. This is the engrafted survival, and you can see in the old days in dotted line that their engrafted survival was poor, even though their overall survival, the dotted line on this right side, is not bad. And that is because of graft rejection. So the pattern of rejection in kids with HERLA syndrome is late autologous reconstitution. So we used to get a lot of graft rejection. So and have to do the transplant again. So the child would survive because the second transplant was effective, but the first transplant was a problem. And you can see in the modern era that the overall survival and the engrafted survival is very good, and that's because we have much lower rates of graft rejection. And I think that's about busulfan. And so I think to maintain myeloid chimerism is about the intensity of the conditioning therapy, and the reason we're much better at maintaining myeloid chimerism in the modern era is simply that we better use of busulfan. So we'll usually use busulfan once a day for 4 successive days. We'll measure the PK on the first night, so we give the drug at night. We check the level the following day in the lab, and we then adjust the dose 2, 3, and 4 to achieve a cumulative AUC of around 90. So proper myeloablative busulfan. And that's just, again, our engrafted and overall survival, indicating that most kids survive and that most kids do not reject. So this is what we do. We give enzyme replacement, but it doesn't make any difference. So we do it just to keep the metabolic and genetics team happy. We transplant as soon as donor is available. So we don't, we prioritize these kids just like a leukemic kid to try and get to transplant quickly. And this is our donor hierarchy. So our first donor is a non-carrier sibling. The second is a well-matched cord, wild type. So we're looking for wild type donors, non-carrier sibling, a wild type cord, 8 on 8, or then a wild type mud, a 10 on 10, unrelated donor before. And then if we're using a mismatched donor in Manchester, we'd use a mismatched unrelated donor. So we don't do many haplos, partly because they might be carriers, and partly because we don't have to. We're in the luxurious position of being able to afford cord and unrelated donors. If we don't have a good donor and we have a carrier sibling, then we may very well do the carrier sibling rather than. So first of all, we do a safe transplant and then secondly, we'll do a wild type donor. So if we've got well matched donors, we'll do the wild type. But sometimes if we've only got very poorly matched donors, then we might use a carrier sibling because the child will survive. And there are minor differences in long-term outcome, but they will survive. This is what we do: 4 doses of intravenous busulfan. We use fludarabine as our immune suppression. We don't do any graft manipulation, but we give serotherapy to all the patients. So ATG with cords, we use a lot of Campath, and so we use that with our siblings and our unrelated. GVHD prophylaxis, cyclosporin steroids for cords, nothing else for muds. And then we give a bit of rituximab with cords, but I don't think you need that. Enzyme therapy, we stop it as soon as we can. And the important thing about metabolic disease transplant is you don't cure the disease, you attenuate it, you make it milder. And so all of our kids, once they're out of transplant, will go into a long-term multidisciplinary follow-up that will include orthopedic surgeons, spinal surgeons, ophthalmic surgeons, cardiologists, and the like. That was just a European look back. And this is why we use cord. It has better outcomes. They're better than these now, but you can see mismatched unrelateds don't do well. And this is Ruby Nadaf, one of my fellows from one of our Indian fellows, a very able young lady, and she has just published this in cytotherapy. So what she shows is that the engraftment, adding on this left panel, this is the engraftment of the cord and the non-cord at the first study. And you can see that cords and non-cords are very similar to each other here with no difference. But you can see as time goes on, then we see more and more donors in the cord and less donor engraftment in the unrelated. So cords will fight their way in and maintain engraftment compared to the non-cords. As on the bottom panel, this is just CD15 and other things like that. But this is the overall blood engraftment. And I think when we look at cords, they seem to have better chimerism, and I think that is the same reason that they get less relapse. and so I would commend you to think about cords, or no, I think we're very lucky. So when we look at this difference between carrier donors and non-carrier donors, so this is our substrate level, and we can see kids on enzyme over here with a lot of residual substrate because of antibodies and because of lack of enzyme delivery. You can see the family donor and the carrier and the unrelated donor here. So there is a difference, but perhaps these are relative differences. And if this carrier donor is much better matched than this unrelated donor, you may think about doing a carrier rather than a unrelated wild type donor, because the differences are relative, not absolute. Cords, yeah, better survival, better chimerism, but probably more graft rejection and more difficult transplant, and of course very expensive. Patient outcomes, and I think this is key, is that engrafting the patient and getting through the transplant is different than correcting the disease. And it's important for us to distinguish transplant outcomes from patient outcomes. Transplant is better at preventing the disease getting worse than it is at reversing established disease manifestations, and that's important. So when you've got a child presenting with advanced disease, probably better not to transplant than to transplant in many circumstances. You might risk even stabilizing a child with poor outcome. So why the variable outcomes for lysosomal storage disease? So some diseases are refractory to transplant. So if you do a transplant really in MLD, no benefit. In 3A, no benefit. The only caveat would be some of the milder diseases. So for each metabolic disease, there will be a spectrum from severe disease through to attenuated disease, depending on the mutation and the amount of residual enzyme activity. And so we might transplant a child with late onset MLD, but we wouldn't transplant an infantile kid. So the disease is relevant. Genotype, as I've just said, milder disease will have a better outcome anyway. Age at transplant, so better, the younger the better, and the fewer disease manifestations, the better. And graft enzyme delivery, which is better in wild type than carrier, and better in fully chimeric recipients than in mixed chimeric. So neurodevelopment actually can be pretty much within the normal range. Some of our hurler kids have been to university, and some of we would expect all of the kids to talk and walk and be very happy in their families. When we look at growth and bones, this shows growth of our hurler cohort. So this line here, the horizontal line, is normal growth. So the dots above that are kids who are growing above normal. So most are slower than normal. And you can see in white is those with a low enzyme level, and in gray and black, those with a higher enzyme level. So you can see that if you're fully engrafted with a wild type donor, your growth and your bones therefore may be better than if you're chimeric engrafted or we've used a carrier donor. Quality of life. So this is just a child health questionnaire where we've surveyed the family for their quality of life after transplant. So you can see these are the summative scores at the end. So this one I'm showing here, the second from the end, is the physical score. So the kids have a residual skeletal dysplasia. They may affect their mobility, and so their physical functioning is poor, relatively poor. So that's the normal here, and they're below normal. This is their psychosocial functioning, and you can see that they're happy kids. They're well adjusted, and they overlap the normal range. There's some kids that have a very poor neurocognitive outcome, and these kids will often be within the autistic spectrum, but the majority of kids are in a normal range, and actually in some ways better than the leukemia kids that we transplant. So I think that the neurocog outcomes are good. What is our practice in other lysosomal storage disease? MPS II, I think, definitely responds to transplant, prevents the somatic death. One of the problems with MPS II is that the boys present a bit later than the MPS I kids because they present later, they often present with neurocognitive delay, and so transplant's less likely to make them better. They have fewer somatic manifestations of disease than the MPS I kids. Gaucher, yeah, enzyme in the UK will be first line in type 1 disease. So the somatic disease, bone and big spleen. And that's treated with enzyme replacement therapy every 2 weeks, but it won't be effective in type 1 or type 2 or type 3 disease, where there's neurological outcome disease, and then transplant might be better, especially in GD3, but it's rarely performed. But we have recently published an international cohort of GD3 kids transplanted. We give enzyme replacement therapies before transplant. The substrate is inflammatory, and we try and reduce the spleen size before transplant. So I think if we are transplanting Gaucher, and I think it is a good disease to transplant, especially if we family or a health system can't afford enzyme replacement therapy, it is good to give some ERT before the transplant. Walman disease, again, we give it, all our kids with Walman get transplanted, but the kids are so sick when they present. We stabilize them with enzyme replacement, which is very expensive. And without that, I think the kids will die during transplant. So if we look before enzyme replacement therapy was available, all those kids used to die. Krabbe, we do not do kids with infantile Krabbe because it's too rapidly progressive. In XALD, so in X-linked adrenoleukodystrophy, so a good example of metabolic disease and planning. So we only transplant kids with early cerebral inflammatory disease. So when we look at the natural history of XALD, some boys are fine, so they don't get any CNS disease, and we do not transplant them even if they're genetically affected and even if they've got siblings who are affected. So we give no role in prophylaxis, and we don't in advanced disease. So if they present with advanced disease, then we don't transplant them. What we would do in a boy that's presenting with neurology is we would screen all potentially genetically affected boys. And transplant, of course, has no effect on the adrenal failure or on the later onset spinal cord disease. So our role when we have a boy who's genetically affected with XALD is we will identify the donor. We're not worried about carrier status. We will identify the donor, and we will transplant with early onset cerebral inflammatory disease on scan. So as soon as we see scan changes, we'll transplant. So as we turn to newer therapy, so this is MPS 1 or lysosomal storage disease. If we transplant with a family donor, then we see correction of the disease. So the somatic disease is better. So we prevent premature death. The brain is somewhat improved and the skeleton less so. And if we transplant with an unrelated donor, we deliver more enzyme, but the brain gets, but we still deliver tissue correction in that order: somatic, brain, bone. If we look at certain other diseases, and let's take Sanfilippo here, then even if we do an unrelated donor, then we do not correct the brain, and that's because it's not delivering enough enzyme. And so we came to the hypothesis that in MPS 3, we should use autologous stem cell gene therapy because transplant didn't work. And we thought that was because transplant didn't give enough enzyme. So MPS 3 is a shocking neurological lysosomal storage disease. So the kids are normal when they're born. They have some initial normal neurodevelopment, but regress from about 24 months. And they have this excitation phase where the kids are not sleeping, running around, no sense of danger. And it's very destructive to families and to children. The disease doesn't respond to allo. So even if we did a newborn with an umbilical cord transplant, which is what we've done, the disease still progresses. And so our hypothesis was if we could take autologous cells here, and this is our lentiviral vector here. So this is what we transduce them with. So we use a myeloid vector promoter. So we use the CD11B promoter, which drives expression of the adjacent enzyme transgene in myeloid cells, and we then transplant them here. So we take mobilized cells, we transduce them in your manufacturing, and we then take the cells back and transplant them after busulfan. And you can see what we do is we get a lot of enzymes. So remember the hypothesis, which is that a normal transplant cannot deliver enough enzyme. And so here's the normal transplant here at the bottom. And here's all the excess enzyme that's coming along in plasma and also in the brain. And then actually the kids that we've transplanted are pretty normal now. 4 out of the 5 are in the normal range, and we're about to start a more definitive trial. So you can see the natural history in grey of regression. The kids that we've transplanted are not regressing. And we've got gene therapy approaches in MPS 3. We've just done a trial in MPS 1, and that's just running between allo and auto. And undoubtedly the autos have got much more enzyme. MLD we already do, and in MPS 2 we've got this. And I think Gaucher disease is a good example, and I think for us all to consider about the pathways to gene therapy. So I think Gaucher is a good candidate disease, and I think it's a good candidate disease to develop a gene therapy program in India. So what we would do first is we would make a laboratory vector, so a lentiviral vector. We would screen different vectors for which one is easiest to infect cells and has the best enzyme. Then we would test that vector and the cells work well. We tested it doesn't interfere with engraftment, so we would engraft human HSC in a animal model. So we've got the vector, we've tested in the lab, we make sure it doesn't affect cell viability, and then we make a vector that we use what we call a GMP vector. It's a bit more expensive, and then we manufacture a product like I just showed you in that schema, and then we run a trial. And I think this is something that we could do together. This is one of the other trials we're running, is MPS 2. Hunter syndrome. So again, here's the promoter, this myeloid promoter in the vector, driving expression of the enzyme gene. But what we've done here is we've linked the enzyme gene to a brain penetrating tag. This is the ApoE2, which crosses the blood-brain barrier. So any enzyme that's made in the circulation can get over into the blood, into the brain very quickly. Just for MLD there, just to show, this is a leukodystrophy child with no transplant. You can see the atrophy and you can see the leukodystrophy, and this is a child that's had gene therapy, so you can see no leukodystrophy and no atrophy. And just the siblings, this is a motor score, never walk because of the peripheral neuropathy, and the transplanted patients are good. So in summary, I'd like to thank you for coming along. What I've talked about is transplanting lysosomal storage diseases, and I've talked about the recent shift from allo transplant, which is effective in some diseases, but leaves residual manifestations in bones in Hurler, when we've recently begun to switch from allo to auto. And when we look at auto, what we're doing is taking autologous hematopoietic stem cells, we're gene modifying them using a lentivector with a myeloid promoter, and we drive huge levels of enzyme in the blood, so 100, 1,000 times overexpressed, and so that large enzyme level in the blood corrects the disease. Of course, metabolic disease is quite rare, and there's a lot of collaborators here, both within and without the UK. And thanks for inviting me, and I'll be very happy to answer questions about any particular lysosomal or other metabolic diseases, and very grateful to be asked. Thank you.
Thank you so much, Dr. Wynn. It was wonderful. It was very insightful. And I think there are a couple of questions in the chat box. I think we have some time, about 5 minutes. Okay, I would let Dr. Gaurav ask the question first since he has raised a hand. Please go ahead.
Hi, Rob. So thank you, Gaurav. I thank you for very, very enlightening and insightful presentation. So I had a few questions. First of all, for your cod, I mean, it's very obvious that for you, the preferred source is cod, based on your decades of experience. Whenever you encounter a scenario where the cell dose in your chosen cod is not appropriate, do you use the cell expansion, cod expansion methods, or like if in one of the cases you mentioned, there were two siblings for whom you used the same cod and it was splitted. So do you expand the cod, or cell dose is not a challenge?
Yeah, it's rarely a challenge because obviously usually the kids are small, so we're very So when we split the cord, it's because the cord is big enough for both siblings, we can just split it at the bedside. We've done that 3 times actually. But yeah, we're lucky. The cell dose is not limiting because because they're small kids. But I recognize that we're in a luxurious position that any cord is very expensive, and we would often do an unrelated donor transplant or bone marrow transplant. So I think the relative arguments in favor of cord are just those; they're relative, and you can easily. It's just as acceptable to do a bone marrow transplant. We used a lot of cords because we can get on with the transplant very quickly. We can get the cord very quickly. And because they have perhaps less chronic GVHD and better chimerism, so that's why we've used them. But I don't think it wouldn't worry me at all to do a bone marrow transplant. If I talk about those 3 kids that are on the ward today, they've all had bone marrow transplants actually because we didn't find a better match cord.
But somehow, like, gods are a challenge here in this part of the world for different reasons. I mean, it's not center specific. We have seen this cord related issues in different centers across the country. So and there are different factors. I mean, availability of the cord, the right cell dose,
Yeah.
the challenges post cord blood transplant, engraftment related challenges. So all those things are there. But if we keep aside cord and look for the other 2 alternatives like a smash family donor or a unrelated donor, out of these 2, what will be your preferred algorithm? I
We
saw
use a
that
map.
third is the mud haplo. Okay.
Yeah,
Haplo will be preferred over mud.
yeah, we would use a mud here, but so actually, Gaurav, you'll have much more experience of haplo than I will. So we would do very few haplos compared to you, just because we can get the mud. Most
Mud
of our
and the cord blood.
will have an unrelated donor. So our donor algorithm will be uh, a matched family donor that's not a carrier, followed by a well-matched unrelated donor or well-matched unrelated cord blood donor, and then we do so few haplos. But it's not wrong. But I can't find myself giving advice to you on how to do the haplo because you know more about it than me. But I think it's reasonable. So what I wouldn't, and one of the points I think that's good to come away with is that in Hurler, I wouldn't worry about being a carrier. If that's your best donor, I would do that. And certainly in Gaucher, I don't think there's really any evidence. I think that is a macrophage disorder, and I think carrier macrophages will be just as good as, or will correct your disease. And we've been corresponding, I think, recently with one of you about that. So, and I think don't find yourself under pressure because of this dose relationship to use a poorly matched carrier donor, so poorly matched wild type donor just because you're worried about using a carrier donor. I think what we would do first of all, do a safe transplant, make sure the
That's
child
true.
wait till the child is alive afterwards, and then go on with the rest of it.
You, Satya, you want to go ahead? Satya?
Yeah. Rob, couple of questions. One is that since a lot of young trainees are attending this webinar, so when you have a metabolic disorder, which is very rare, like 1 or 2 transplants have been done, or there is very little data in the published data in the literature, yet it is curable by transplant. So, can you highlight how you go about ethically? How do you make a decision that I will do the transplant or not do the transplant? I I think briefly you can tell about your metabolic tumor boards you have in your place or something like that. And the other question is that when not to do the transplant, like you know that this metabolic disorder is curable by transplant, but now the child is not fit for transplant, so not to do transplant. So these 2 things. Thank you.
Yeah, very good question. So there's lots and lots and lots of rare metabolic diseases that come along and you wonder whether to transplant them. And we would be very happy to discuss them. But sometimes we don't have the answers. We did a transplant, for example, in a kid with sarcoidosis recently, which is a lysosomal storage disease, but it didn't get better. So the kid has progressed several years after the transplant. So we'll try and one of the learning points is to try and publish those things, just even the negative ones, just to try and help the community. But it's very difficult. We do have some in vitro cultures, in vitro tests where we culture a wild type microglial line with patient fibroblasts, and we measure the residual substrate in the fibroblasts, and we try to get an idea from that whether there's enough enzyme coming out of the microglia to correct them. But in the end, you're just going to have to do it. And we'd be very happy to participate in Minneapolis, the same, the other big transplant center. For advanced kids, that's very difficult, especially when a family want you to do everything. But and I've done lots of transplants that I regret because the baby looks okay, looks like a baby, and but actually the parameters might be of advancing disease, and you just don't reverse that. So certainly for neurologic disease, if we think about a patient with neurologic disease, then the time for the transplant to get into the brain is many months, because you've got to wait for the transplant, you've got to do the condition, you've got to wait for engraftment in the blood and then engraftment in the brain. And so I think I would be cautious about transplanting boys and girls with advancing metabolic disease, even though the family are pro-transplant. Although we will also do some older hurler kids to prevent the somatic death, and some of those will do okay. So I don't think there's a definite line in the sand. We will do many kids with hurler over the age of 2, because they come later, and especially if they look good. So we don't have this absolute cutoff at any point, but we will look at the kids and counsel the family appropriately, which is that if you're doing it late, the outcome won't be as good as you're doing it early. But for the child in front of you, you can't change that. So what we try to do is make a full assessment of them and have a look at what their neurocognitive performance is like, and then try and reduce the interval between diagnosis and transplant by fast tracking these kids and giving them the priority in your transplant unit as you would a difficult to cure leukemic kid. So but very good questions. I think there are many difficult diseases. I think someone's put in the chat about fucosidosis. We've only ever done one kid with fucosidosis and she progressed, so I don't think we'd be in a hurry to do another one. But there are other diseases that you might think are refractory but seem to respond well, Farber disease and the like. So I think in principle all lysosomal storage diseases can respond to transplant, but most of our work is taken up with MPS 1, then MPS 2 and Waltman. And I think the big indication that we don't transplant is Gaucher. So I think type 1 Gaucher responds well to transplant. Poni's put a question in about splenectomy. Very good question. That I think in the 1990s, when a lot of transplants in Gaucher were done, the next splenectomy was a good idea. I think what our usual advice here would be is that we would give enzyme replacement therapy to reduce the amount of substrate in the body and to reduce the spleen size, and do it that way, and then transplant, rather than doing a surgical splenectomy. So I think that's the way we try to do things. I think when kids engraft with Gaucher, you can see an inflammatory engraftment. Suddenly the enzyme competent cells release a lot of substrate, and I think I would just be cautious about that. And again, that's why we would try and reduce the amount of substrate before. I think it's sometimes possible to get compassionate enzyme, and we're certainly happy to try and help that if we can. But I think in Gaucher, it's a good indication for transplant. I think it's okay to use a carrier donor, and we would try and give some pre-transplant enzyme for 6 to 12 months to try and reduce the spleen size and reduce the inflammatory burden. But it's a good indication.
In some cases, Rob, we have seen that despite giving a fair trial of ERT for Gaucher's just to bring the spleen size down before transplant, still the spleen size remains the same, or there's not much change. So in such cases, what would be your suggestion?
It's a good question, and I certainly, when we treat the kids in the UK with they're probably younger with enzyme replacement, then the spleen does come down in size. If it isn't coming down, what I would do is that I'd have a conversation with us. We have a young woman in our team called Amy Donald, who is a world expert on Gaucher syndrome, and I think we'd take her advice there. So please set up if you email me with that question, I'll bring Amy in. So Amy's just reviewed all the kids in the world with that we've done Gaucher transplants in for neurologic disease. So and in those kids, transplant is effective, and it also, even though we're doing it for neurological disease, it corrects the somatic disease. I actually think Gaucher is a very good indication for transplant.
Thank you. I think
Professor
one last
Bin,
question from
the
Satyendra.
last, Hi, Professor Bin. Thanks for the
Hi.
talk. It was a lucid one. So my question is, for those patients where in the Western world they are very sick to take the conditioning, and then I add most of our patients from the developing world where the enzyme replacement therapy is not easily available, and they want, or we want them to undergo transplant. Now there is on board this anti-stem cell antibodies, at least they are into the Fankin and all that. Do you see that maybe in 2, 3, 5 years, if we have antibodies available as a replacement of conditioning with serotherapy, those sick children where like Wolman disease or the patient who have not received ERTs will be better transplanted, or maybe from the autologous gene therapy? Do you see a future for them?
Yeah, it's a very good idea. We haven't gone down that route. It won't engraft the brain, which is a problem, I think. So you won't empty the niche in the brain. So in the neurologic disease, I think we'll always need, well, at the moment we'll need something like busulfan. But it's a very good question. I don't know that way forward. In the Wolman kids, I think you'll end up, however you condition them, you have to have stabilized the disease with enzyme in some way. So Wolman untransplanted is such a rapidly progressive disease. And so we did a few years ago, infants presenting with Wolman with, cachexia, diarrhea, liver disease, and they all died in transplant just because we couldn't get the graft in quicker. So it just couldn't get the enzyme in quick enough. And then more recently, we've been giving them enzyme replacement therapy, stabilizing the disease, and then transplanting them. So I think even there, in the rapidly progressive ones, it's going to be hard, whatever you do. But I think, maybe, and we've wondered about antibody conditioning and things, but we've not got there, and it isn't dramatically successful anywhere yet. And you may not get long-term donor chimerism, but you may use it to stabilize you. So very good question, and I think we'll all watch that space together. But we haven't got any open program to look at that at the moment. We've concentrated on making them fit for conventional transplant. But it's a very good question.